and you will remain happy and healthy. We are able to finish almost all what we are supposed to learn in our MSK. And today I'll be talking about the last topic. There I will be trying to go over foot and ankle joint. And after that, I'll be left with one lecture that will be targeting the clinically relevant things which are related to both my upper limb and lower limb. I'll try to go over as much, but sky is the limit, and I will bring what is more appropriate. Otherwise, everything is interesting. When we start talking about clinics, it's all full of, everyone is liking that, and I know that, but we have to look for what is exam and when it is there, and we'll continue, inshallah, to talk about things. So now, I hope there are not any major questions because I can see inbox. It's not really talking about chill, relax. Everything is done. Yeah.
You're the boss. Thank you.
You're welcome. Just chill and relax.
Is the Zoom on?
Everything is on. Okay, guys. So, without any further delay, I like to start what we're supposed to learn today. And as I had mentioned, we will be talking about the ankle joint and the foot. So let's begin the ball rolling. And there you are looking at an image. It's not image, it's a drawing of a foot where I'm showing you the names of the bones. Guys, in today's presentation, there is a lot which you have to see only. Don't try to read it even. And when I'm saying don't try to read it, I mean to say don't try to memorize it. There are certain relevant, important things where we'll be focusing on, and there are few things which are there. A lot is there, but we are not supposed to cover from cover to cover. We are focused and targeted, and we will be talking what is more relevant today. So with that note, I'm starting here, and this is a foot, is a drawing, and you're looking at a bone which is being given a different color. This is my calcaneum, and these are just labels. There's no rocket science here. Nothing new. So now, what we see here and how it is different from my bones, which makes my hand. In the hand, we talk about the carpal bones. Here we are talking about the tarsal bones. Carpal bones have their names, tarsal bone have their names. And there's a series of these bones: callus, calcaneus, talus, cuboid, cuneiform, navicular. After that, we have metatarsals. We don't call them metacarpals because those words are dedicated for the hand. To differentiate from the hand, we use the term here metatarsal. And then we had the phalanges. Phalanges remains phalanges. And then you can see proximal, middle, and distal, and it stays true for my big toe, where I have only two. The others are three in number. If you know this much, enough. You're not expected to go in further detail. I remember the days, 1,000 years back, people have to learn about fine detail of every small, tiny bone. That era is gone. It's left for whom? If you want to pursue your career, you become a surgeon, an orthopedic surgeon, and who's dedicated only dealing, it's a subspecialty, only dealing with foot. Then you may need to know. Or you are a classical anatomist. But that is not decided today. So don't invest in that. Once it comes, you can take it. The sole idea is, let's not increase your cognitive load. Let's talk, focus what is clinically relevant and what is needed for you tomorrow. And then you want to build on, you can, you are given the main plot. You can build on that. But let's not put time for this. So this much you should know from the bones of the foot. Now, there are so many joints, but I'll be talking only about few of them. And this red line, it indicates what? This is number one, and it says transverse mid-tarsal joint. Why we call it transverse? It runs, it's present transversely, and it is between mid of my tarsal bone. There's no rocket science in the name. A joint which is between my tarsal bones, I call it, I have all the rights to say it, a transverse tarsal joint or mid-tarsal joint. There's nothing special here. And then this is between tarsal and metatarsals. You can make out name yourself. So what has been said? Tarso metatarsal joint, and then first, second, vice versa. Are we good? So now, going further, so these are tiny joints, interphalangeal joints, proximal, middle, distal. We talk about this organization remains the same as we were talking for the upper limb. Now, what is expected from you if you are looking into, I'm sure you'll not be getting an image like that in your practical life, but at least people should understand which bones here are tarsals, where is my lower end of the tibia, and where are my metatarsals, and where are the phalanges. If you can identify this much, enough. You can see there's a lot under these bones. There are a lot of cushions. Now, this is how this image has been labeled. And this is simply just to know, just to see what is happening. So now what I'm started to talk. Guys, now watch the speed. And you just, the point is go through the process. So I'm putting up the layers. Why I'm going fast? I don't want you to spend time on this at this time. There are so many intrinsic muscles of my foot. They are going in randomly in different directions. We talk about those. So they are going forwards, a lot is happening. Is it fine? Did you understand anything? That I want. So don't put your time in these. So where you should put time? The story begins here. Gentlemen, do you mind closing the lights? If I could have spent time, the discussion, the part which I've shown you, I've been through fast. It took around minimally good 6-7 hours. For understanding, we need a lot. But only we learn from these slides is my foot has layers of structures. And these layers, these are primarily muscles. In between, I have different neurovascular bundle. So these layers, some facial layers. So this makes all together. So in principle, what should be known to you? My foot has 4 layers of structures, and you have seen them. And I'm sure you don't know them. That's good. That's needed. So now, but we should not forget. We talk about arteries. Let's recap. The arteries, we talk about femoral artery. That was the continuation of my external iliac artery. External iliac artery, when it passes under my inguinal ligament, it changes its name to femoral artery. Femoral artery, when it passes through the adductor hiatus is located where? in the substance of adductor magnus muscle. When it passes from that, it reaches to the back in an area which is behind my knee joint called popliteal fossa. Now, the moment it passes through, it exits through this adductor hiatus. The femoral artery is called as the popliteal artery. This popliteal artery, when it goes down, it crosses. So when it gets out of this almost popliteal fossa, it bifurcates into anterior tibial and posterior tibial. So this anterior tibial is primarily responsible to supply my anterior compartment of the leg. We learned those muscles and those were extensors. The nerve of this compartment was deep fibular nerve, which was a branch from common fibular nerve. And common fibular nerve is one of the major contribution coming from my sciatic nerve. And sciatic nerve was coming from my sacral plexus. Are we good? So now this anterior tibial artery is responsible to supply my anterior leg. Posterior tibial artery, it gives a femoral branch. That is for the lateral compartment group of muscles, and there I have two, fibularis longus and brevis. And their nerve was superficial fibular nerve. And they had a specific job to do. We talk about that. They were responsible for eversion, where we will be learning today, where. Then the posterior tibial was responsible to supply what? The muscles who are present in my posterior compartment of the leg. And we learned these muscles in 3 layers. These 3 layers, 2 layers, 1 layer, we create for our better understanding. Actually, there are no layers. We had group of muscles who are present in different parts of my body. So we learned 3 layers, and first layer we dedicated for gastrocnemius, second layer we left for soleus and popliteus, and then the deep layer we put 3 muscles there, we talk about those. So now, after that, we have gone through these muscles. Primarily, we talk about that these muscles which were present in my anterior leg, in my lateral leg, in my posterior leg, they are the extrinsic muscles of my foot. And then we saw a big number of intrinsic muscles of my foot, like we had intrinsic muscles of the hand. And these muscles, it's okay. Only you need to know we have a number of intrinsic muscles in the foot. But foot has 4 layers. And these layers, they are sandwiching some of the neurovascular bundle. So now what are you looking at? You're talking about arteries and nerves of the foot. That we need to know. There we are expected. So this is my anterior tibial artery. So we are approaching from the dorsum of the foot. So anterior tibial artery, we all know, when it goes little down, when it continues its journey, it reaches near to the tarsals, it changes its name. Now we call it, there's no really cutoff that at what level you can say precisely that anterior tibial becomes dorsalis pedis, but it becomes dorsalis pedis. If we dig back, we may find, but I don't think we are bothered. We should be bothered for that. But be reminded, finding pulses is really a relevant thing, and you are expected to know where and how we can look for these things. Let me talk about, it's very difficult to feel popliteal artery in the popliteal fossa because it's very deeply situated. It's the deepest most. If I talk about the contents of my popliteal fossa, the most deep structure located in my popliteal fossa is popliteal artery. So now, coming back. So this is now anterior tibial artery continues as dorsalis pedis artery. And then you can see it's going inwards between my big toe and the second digit. And this we call it as the one who's going inward. We call it deep plantar artery because it's going to the plantar surface of my foot. My foot has a plantar surface and a dorsal surface. My hand has a palmar surface and a dorsal surface. So guys, these differences, you should be good at it. So this is that was my deep plantar artery, and there is someone else. which is going laterally towards my fifth digit, and that is lateral tarsal artery. It's going laterally on the tarsal bones. It's a branch from, you can figure out yourself. And then we can see the one who goes medially, it should be medial tarsal artery. Are we good? Now, can you notice what happened now? There is an arch which has been formed here. The contribution is coming from my dorsalis pedis and lateral tarsal artery. They made an arch, and this arch, it's like an arc. We call it arcuate artery. And this arcuate artery, now look at it, dorsalis pedis supplies on the medial side of my big toe. What is that? Dorsal digital artery to the hallux. It's not pollicis. So it's dorsal digital artery on the medial surface of my hallux. And then from my arcuate arc, I have a number of branches. Who are they? These are dorsal metatarsal arteries. Why we call them metatarsal? Because they are running on the metatarsals. And further, they branch off. Dorsalis pedis itself is responsible to supply the lateral aspect of my hallux and the medial aspect of my second digit, and the remaining are getting their supplies through the arcuate. You are expected to be clear about this concept. It's very simple. There is no rocket science here. Are we clear so far? Okay. So now let's make it more complicated. Let's bring a nerve here. What nerve this should be? Anterior. Do we need to call it anterior? No. Think again. My sciatic nerve, bifurcating in popliteal fossa, in tibial and common fibular. Common fibular at the neck of fibula bifurcates into deep and superficial fibular nerves. And deep fibular nerve was coming anteriorly and supplying the muscles who are there. The muscles were tibialis anterior, extensor hallucis longus, and extensor digitorum longus. And the superficial one was going to fibularis longus and brevis plus minus tertius. So this is what you're looking at, deep fibular artery. Still people call it peroneal, so don't get mixed up with that. And now you can see it's coming down in my first web space. So deep fibular nerve supplies the web between my first two toes. And here it's sensory. It becomes sensory here. So if someone has multiple trauma that affect his whole lower limb, by just touching between the big toe and the digit next first web space, if the person feels something by touching there, I can say, yes, to me, the common fibular nerve, deep fibular nerve looks all right. Means sciatic looks fine. Because at least I can perceive the sensory part. So by simple touch and feel, by look, you can look for a deformity, and simple touch and feel can give you integrity of the nerves. Simple pulsations can help you to understand that artery is working or not working, artery is blocked or clogged. Are we good so far? So there, we can see someone else who's coming down. Who's this? Which is going to my second, and then I have multiple. And what are these two? They are named here as medial and intermediate dorsal cutaneous branches of my superficial fibular nerve. So they are superficial fibular nerve. So on the dorsum of the foot, my primary supply is coming from superficial fibular nerve, which is a branch from common fibular nerve. But my first web space its supply is coming from a defibrillator. We need to be good with that. So now you can see that how it is supplying and where and what is happening. And you can see all the digits getting their respective supplies. And it's going laterally, it gives a lateral branch and it gives a medial branch. Are we good? I don't see there is any rocket science. We saw anterior tibial artery and we saw what happens distally, terminally to my deep and superficial fibular nerves. Now let's look at the plantar surface of the foot. On the plantar surface of the foot, we can figure out the one which comes medially, then it deviates to the lateral side. That's my posterior tibial artery. Now, you may say, guys, this is a typo. It's written here, medial plantar artery. Actually, it should be lateral plantar artery because it's going laterally. And this one, it makes deep plantar arch. It's something like, and you know, it's anastomosing with whom? With my deep plantar artery, which was given by dorsalis pedis. You remember on the dorsum of the foot, that was going through this space. So we have now an arch. And now this runs medially, but it is written wrong here, typo. It should be medial plantar artery, it's written as lateral plantar artery. And now it is supplying branches. And now from my lateral and medial, you can see the way they are distributing on the plantar surface of my foot. And they have their names. Any rocket science? Anything new? Only you need to learn the names according to the region. And you are knowing what are the resources. Primarily, my posterior tibial artery. It gets a contribution from anterior tibial artery when it was making an arch. And that was my deep plantar arch. So nerves, same. Which nerve should be this one? Tibial. Thank you very much. Don't call it posterior tibial. So this is my tibial nerve. And again, its branches, same typo are here. Ignore them. And same way of distribution. Are we fine? Any issue? So we have talked about the arteries and nerves who are present on the dorsum and the plantar surface of the foot. You may ask me, you have the right to ask me that you always talk about arteries and nerves. You don't talk about veins. Veins we talk about separately because veins have a different plan. So veins are superficial vein, deep veins. Superficial veins here makes deep arch, dorsal arch, and that is responsible medially and laterally. Medially it continues as the great saphenous vein and medially it continues as small saphenous vein. And we saw that these small saphenous vein and great saphenous vein through multiple perforators, they are connected with the vena comitants of my anterior and posterior tibial arteries. And now the great saphenous vein, it goes and drain into what? Into my femoral vein. And the small saphenous vein, it goes and drain where? Into my popliteal vein. So that ends my veins here. But more we need to know about the arteries. But it doesn't mean that veins are not significant. Veins are significant, but we have already talked about them. Like in my previous session with you, I spent good time only talking about veins. How the blood is being pumped upwards. Now, guys, if we are learning foot, we are learning foot for this point. We have arches. What are these arches? To understand these arches, let's talk something out of the box. You put money on a car. When you're buying a car, what is your criteria of buying a car? This question has no scientific relevance. You can talk freely. Safety, excellent. Efficiency, comfort. So for safety, what is your criteria? It should be a big car, a strong car, built on, if I have a choice, built on a chassis. There is less likely chances of getting sandwiched. Then, one last word which has been mentioned on the basis of comfort. What gives you comfort? The cushioning, and if you look in the bottom of the car, suspensions, excellent. If I have to put money on Bentley, I have a reason for that. If you're buying a Phantom, fine, your choice. You have money, do it. But why? Because if you take ride in these cars, you don't feel. Your excursion is so smooth, you cannot imagine. I'm sure you must have tried sometime. If not, you should. So, this smoothness comes from what? An excellent masterclass suspension. Okay, this is one aspect. You buy a very nice sports car, top of the line, any best model of Lamborghini. You spend, you have a ride, 2 hours. When you get out of your car, what is your comfort level? Tell me truly if you have experienced that kind of thing. Because the sports cars are not designed for comfort, they are designed for speed. So they are minimizing other factors. They are designed for style and speed. The other cars are designed for luxury, comfort, and other things. So everything has a purpose. So my hand was designed for grasping, for comprehensions, for precision, and my foot was designed for comfort. You walk, you run, you're okay. But sometimes you are interested in joining forces. There's an interview call, you applied there, and all of a sudden you notice, after your physical examination, you notice you are rejected. You had a big question, why I'm rejected? I'm smarter than others, those who are selected. I know more than them. My build is good. I'm more muscular. I'm more educated. Why I'm rejected? The answer comes, thank you very much. Gentlemen, you have flat foot. So what is this flat foot? This person has everything, but he misses one thing. And that is, his foot doesn't have arch. So if my foot don't have an arch, I walk a little. Initially it's fine. Then it's become very painful for me. I cannot continue to walk. I cannot continue to run. And see, if you are a soldier in a force, every person is a soldier. No matter you ranked chief or you ranked a simple basic soldier. Your basic job is to fight. And during fight, there is no question of comfort. All these sports cars are designed to run. So nobody complain for comfort. Because if you complain for comfort, somebody will say, okay, why you bought this car? Go for a luxury car. Make sense? So if someone is flat-footed, after walking or running a while, this person will become tired. Tired in comparison to his peers, his other colleagues, his other friends. He cannot make long distances. So on that ground, he's rejected. But if there is a job where he has to sit in a control room and he has never to run, he has never to do anything, maybe he's taken. So these arches are important. And in the foot, the nutshell is we have to know to our level best about these arches. How how and where are they and how they are made. So I'll try to show you, I'll try to highlight some of the factors. I cannot cover the full detail. The idea is, let's give you a blend. Let's give you a thinking process. So now, stay with me. So you're looking at the medial side of my foot, and the heading says medial view of right foot, and what is coming up here? Let's see. So now, on the medial side, we can see these bones. What's wrong with you? Let's label it. This is the lower end of the tibia, and these are the bones who are contributing there. The talus, calcaneum, navicular. We talk about these arteries. No problem. We are good with that. We saw these. No rocket science. So this, the place where I put a star. What's that? Can you read it for me? Loud? Excellent. So, time comes where you have to take the distal pulses, the peripheral pulses. So you should be knowing a specific location. I put my hand here, I will get this pulse. I'll put my hand here, I'll get this pulse. And this is expected from you to be known. You should be very clear about these facts, because these are the basic learning principles. So now, these arteries, you can see how freely they are communicating. Now, what's that? From where it has come all the way. What you are looking at? Arch. Is there any support for this? It's a real picture, it's not fabricated. Who's supporting this? This arch is supported by what? Two pillars. Is there any concrete structure? Is it man-made or God-made? So God-made. There is no steel inside. It's all rock. And underneath is sea. So this is something we call it arch. And if you are asked to build something, if a human is asked to make something like that, then a human will try to do what? We need a solid surface to establish, to make an arc. This is the arc. But how? What are those factors which helps me? So let's make an arc. So we are taking these stones. There is nothing else. So what are those factors which keep my stones in place? In older days, the time where people don't have any steel, don't have any concrete, they just put these rocks, and these kind of arcs has been made, and these arcs were made on water courses. So their horses, their horse carts, other things, they can go very easily on top of them with the weight, and they never used to collapse. Still they are existing. If you are visiting some areas where you can see the old civilization, you'll find these type of arches a lot. Even in villages and all those, you'll find still today. So I don't want to name the location. You all know. I know you all love excursions. So what is the factor? There is one stone here. If I remove that one, this whole arc will fall down. And who's that one stone? So if I remove this stone, the whole arc is based on this stone. And this stone is the important one, and it has a name to it. Weight is being put here, and this is my keystone here. If I remove this, if this stone is damaged, this arc will not survive. So we call it a keystone. So we have established an arc. by a keystone, but still I'm not happy. I want to make it more stronger. So how I can make it more stronger? And in my foot, who's that arc? Who's performing this keystone function? My bone called talus. Talus is the one which is the bony factor in maintaining my arches. And now we can put staples. Are we fine? We put staples, something like a staple. So what is this staple? Is an example in my real life. So these staples are ligaments between bones, between my tarsal bones. So the ligaments who are connecting, they act like staples. Something binder. We all know what staple does. It clamps a cluster of papers in one place. And you try to rip it apart, you have to apply a force. So first factor, to make this arc as a functional arc, we need staples. And we are provided with ligaments. They are a substitute for staple. Then we have to connect the bottom by a bar. So the two ends, I'm sure you all have seen archers and the bows. There's a string, and when the archer aim an arrow, he has to pull that. And due to this tie bar, this arch remains an arch. If we remove this thread, this become a straight stick. The stick is flexible, but how it remain in an arch shape? There's a tie beam. So there's a tie beam. Who's my tie beam in my foot? So this tie beam is again long and short plantar ligaments. And then I have other structures. What are these other structures? Aponeurosis, muscles. They all are acting as a tie beam. So they are pulling the two ends, so it should remain an arch. With each of the tarsal bone, we are provided with ligaments. We have a keystone. So all these factors are contributing. We cannot say this is the only factor. We had multiple factors. Now, we need something more. I'm sure you all have traveled overseas in different countries. Even I know there is no sea in Riyadh, but there is a hanging bridge here. I'm sure you must have gone through that. So what has been done? You put these tie beams, and I'm sure everybody has seen these kind of tie beams. There are a lot in US. When you travel from different states, in between different states, you'll find these. So these tie beams, they support this arc. And we have one in Riyadh, the hanging bridge. If you have not seen it, plan it. Right? So these are different factors. So what are the examples for this? For these suspensory supports. So these suspensory supports are, what are these? Tendons of leg muscles for dynamic support. What are these tendons? Tendons of my anterior leg muscle group, tendons of my lateral leg muscle group, and tendons of my posterior leg muscle group. If they are coming down and getting attached onto the different bones of my foot. Are we good? Any ambiguity, any question, any concern? So if we go with this thought into a human foot, we will find this all. And that's the basic principle. That makes and maintain my arches. So what happened with these people who become flat foot? Their muscles, their arches, they become problematic. It could be a developmental issue or it could be a later part. And then there are so many treatments, remedies and everything. And that's there to support. Look at it. One example. For those who have problem with their arches, special type of foot care has been designed and it's available. But it's not like you go and you wear it. You should be evaluated first. After evaluation, They measure, and then you are provided with insolers. They fit in your, if you have minor degree stuff, they have been fit in your shoes, and they can help and support your foot. Nowadays there's a lot of trend of having gel and all those type of things. They are for comfort, for shock absorption. But those people who had this flat foot problems, for them there are special type of tailor-made, these insolers are available, and there are so many custom made. And in good stores, back home I have seen a lot. You go in any Walmart like place, there's a machine sitting. It's a tall machine. You can go and stand in that, and this machine will direct you and will give you a rough calculation and then recommend you buy this one. It's lying in this aisle, and you can go and grab that insoler. That will help you. So it's in simple stores it's available. But those are for minor issues. But those who are affected badly, they need more precision and more tailor-made stuff. So these problems can be minimized. So those who have flat foot, guys, there is no bad day for you. You can get it cured. I'm not saying cured, but you can get a relief from what you're suffering. And that's what the job of you and me, to help and learn and do things. So these insolers are there, and they are helpful in maintaining my this A, B, and C. What are these A, B, and C? We'll be learning shortly. So now, before talking that, I'll be starting side by side. I'll be talking about the ankle joint, and then I'll be talking about subtalar joint. We use two terms when we were talking about the muscles of my leg. We use the term dorsiflexion and plantarflexion, and then the other term which was used, eversion and inversion. So plantarflexion and dorsiflexion is being carried at my ankle joint. And there is another joint which is subtalar joint, and that is primarily designed for my eversion and inversion. So these are different entities. These are different joints. So when we are talking, we should talk with reference to these joints. So ankle joint, typical synovial joint of hinge variety. We don't have any rotation. And if anybody has a rotation, that is a disaster. We'll see it, what happens. Okay, so now let's look at a foot. Let's try to make a joint plus establish the arches there. So we are good with the names of the bone. I don't see we talked a lot more time. Now, what is that? Medially, this structure is a ligament, and we call it deltoid ligament. We learn about a muscle called deltoid. Now we are learning, so these are two extremes. One was at the tip of my shoulder, and other one is at my ankle. Place where? Medially. Medial malleolus, I'm sure everybody should know. The lower end of my tibia is medial malleolus. The lower end of my fibula is lateral malleolus. So this one is my deltoid ligament, and deltoid ligament has different parts of it. What are the different parts? You can see someone is going posteriorly, inferiorly. So this is my posterior, and between which bones? Tibia and talus. So posterior tibiotalar, and what it should be? Tibiocalcaneal, going forward to the navicular bone, so tibionavicular, and then anterior tibiotalar. So these are the different components of one structure that is called as deltoid ligament. Place where? Medial. Are we good? There's no rocket science here. Now, this is we are looking at the foot from medial view. So this is my medial longitudinal arch. When we talk of arches, we'll talk about the longitudinal arches and we'll talk about the transverse arches. Longitudinal arches are more effective. And this medial longitudinal arch is the strongest one. Now a question arises. We are talking about flat foot. How I and you know that we are having a flat foot or not? What is a simple test? Think. Hmm? Looking at, wow, what a great doctor you are. Excellent. Excellent. Put some paint, some ink, but make sure it should not be permanent. Otherwise, your foot will be painted. Like the good shoes, the bottom is red color and all that. So, put your foot on a paint and just after that, keep a piece of paper next to it and put your foot on that. If you can see the whole footprint is visible to you, oh, you're flat-footed because the whole foot is, if it is flat, every medial and lateral bottom will be touching on it. But if you see some part is there, some part is missing, Alhamdulillah. Say Alhamdulillah at that time that you are not a flat foot. Okay? And if you're a flat foot, still say Alhamdulillah. You should look for a solution. Solution is there. But solution we'll get when we look for it. It will never come. I really like somebody wrote me yesterday. Can you tell what you have posted on the Moodle and what you have not posted on the Moodle? I was really, stunned for 2 minutes. That now is this a job for me left? Then I said, fine, need not to answer this email. I will answer in front of everybody. So it's your job. Go search in the Moodle. Everything is there. Somebody was asking me, yeah, it came, I think, last around 2 o'clock. That guy was asking, I haven't find the lecture on autonomic organization of autonomic nervous system. I wrote to him, kindly go to the recording of organization of peripheral nervous system, and I'm sure you will get the answer. So sometimes you have to write like that. Because people, it shows very clearly that how much you are connected. You ask me to find out that, you ask me to write that. No, please learn to use yourself, do it yourself. Then maybe somebody asks me, can you write this answer for me in exam? Great. Anyway, we are learning every day. So, guys, so we are looking at medial longitudinal arch of the foot. And now I think I have to minimize this thing. It might be obstructing. Fine. So now what's happening? It's angry because I move him. Yes. So now there is different bones, their names has been mentioned that they are taking part in making. And what are those names? Calcaneus, talus, navicular, medial two cuneiforms, and first two metatarsal bones. So they are contributing. These are the bones who are taking part in making my medial longitudinal arch. And now the keystone we talk about is the talus. And now the longitudinal arch, what are its supports? So let's try to put things here. So there we can see something, and that is a ligament. That is a name. We call it spring ligament. It's not Ottoman spring. Its name is a spring ligament. Now, there is someone else. Short plantar ligaments. If that is short, that should be long. No rocket science. So everything, every structure, and in front of it, it's written. It's an example of what? It's a tie beam, it's what, and it's what not. So long plantar ligaments, and then plantar aponeurosis. Guys, this plantar aponeurosis, plantar fasciitis, is a very commonly affected problem. And so many people are affected by that. You cannot touch your foot on the surface. Don't think you have flat foot. You have an inflammation which is occurring in the plantar aponeurosis, and it restricts your movements. Then you have to have, you need therapy for that. You need to have steroid injections, strong analgesics. You have to wear special type of footwear. You really, and it's not like to be solved in a day or a week. It stays for long. I remember one of my colleague here, he's teaching you. I don't want to name him. He will be angry why you're naming him. So he was having it, and it lasts for him more than a year. Yes, what was your question?
The spring ligament, do they have a weak ligament function?
Gentlemen, I told you, if you allow me to go in this much detail, bring time for me. I love to talk, but every time I'm just looking in my device, how much I'm left with. So that's what. So now this is what. These are my muscles, a big series of muscles, plantar muscle. I have shown you. Simply remember, these are intrinsic muscles of my foot. Now, my suspensory thing, which is coming from the top, and who's that? There's a long tendon, tibialis posterior, which is pulling it upwards. Are we good? So these are roughly the factors which are responsible for the maintenance of my medial longitudinal arc. And now let's look at laterally. It's not that well established. If I compare, look at it, very nicely made, very established. But if I go forward, it's not that high. That's why when you take a print of your foot, you'll see on one side your lateral body is almost touching, but the medial body should not be touching. If that is touching, I'm sure you'll have a flat foot. I wish not. So now the names of the bones all are here. So now more ligaments are showing up. So what are these? Anterior. So these are lateral ligaments, and then anterior tibial-talar, posterior tibial-talar, and then the names have been given. And now what are they called? Medial side we learn about deltoid. Here we talk about lateral collateral ligaments. And then we have ligaments which are connecting top, and these are anterior and posterior tibial-talar ligaments. And now this is my lateral longitudinal arch. Now the keystone remains the talus. So what do we have? Short plantar, long plantar, the tie beam thing, same stuff here. And who's the suspensory support? Fibularis longus and brevis must come here. Fibularis longus and brevis tendon, they are providing the suspensory support here, primarily. Are we good? Now, so they are pulling it upwards. Guys, you are expected to be not good, best with these arches of the foot. Now, let's look at the joint complex, subtalar joint. Who contributes here? These are the bones, which has been marked darker in color. So these are the bones which articulate with my talus. Talus has been removed because what we are learning, subtalar joint. If I put talar here, you cannot see who articulates with the talar. So talar has been removed from here, talus has been removed from here, and this is where it articulates, and these are the ligaments. We talk about what type of joint it is. So there's an articulation, anterior articulation, and this must be my posterior articulation between talus and the talar bones. Now, ankle joint, most commonly injured joint in human body. One of the most common. These are my lateral and medial malleoli. These are what is that? Intraosseous membrane, talus, calcaneum. There is a ligament here. We talk about some of them. Now, who is this? Medially, medial collateral, and this should be lateral collateral, or we can say vice versa, radial collateral and fibular collateral. Now, injuries of my ankle joint. What happens? You're walking, you're not careful, or you're running, you're playing football. Your foot got twisted because surface was uneven. You're not really careful. There's a twist occurring. And what that? Hyper eversion. Result in what? Can you see that? A ligament got torn here. after hypereversion. And now this is a very commonly affecting injury to us when we are playing. And what is the treatment? What you should do? I'm sure we all must have experienced this type of problem. Man, that is something later. Thank you very much. The first thing is ice. Don't put hot packs. Put ice, sit down, rest, pain relief, any painkiller, any tab. It's your choice. Tylenol or whatsoever. After that, you think, it may swollen. If it's swollen, think of something more. So there are grades and degrees. We are not going in that. This is not an orthopedic class. This is just talking about a simple twist which occurs at your ankle and most commonly affecting you. And we need to know about this. Look at him. What this guy is doing while he's playing basketball, look at his foot. It's twisted. And what will happen now? So he has facing a damage to which muscle? Anterior talofibular ligament, and that is torn. And then if a ligament is torn, we need further. It's not ice. First thing is ice, no matter what is gone. But then subsequent. Now, a very common fracture which occurs at this level and usually needs surgical intervention. And that's famous as Pott's fracture. Guys, this word Pott's is being used at different places. We have a Pott's disease which affects the breast. And here this Pott is basically affecting is around your ankle joint. So in this fracture, look at it. Look at this calcaneum. There is a force. There is some rotation. And now look at it. It's hyper eversion, and as a result, injury, fracture. So I have shown these arrows. Some of them are full, some of them are empty. So the full ones are showing what? The full one are showing fractures, bony fractures, and the empty ones are showing what? The ligament tears. Are we good? So if somebody has all this, it needs fixation. And that's known as Pott's fracture, and it occurring where? At the level of the ankle joint. Guys, these things have a lot of detail. I love to talk, but I don't want you to get into so many details. Simply learn that what are the losses, what are the possible losses in Pott's fracture. These are the ligaments, these are the bones. That's it. Otherwise, they all need full time. Now, in the foot, we talk about this. Flat foot, and they use another name for that, pes planus. That's another name for saying flat foot. So this is how you should be able to differentiate. If you dip your foot, and those who are flat footed, their print will be like this. And if you're normal, the print will come something like that. Are we good? So now, that completes the story of MSK. We are done, Alhamdulillah. And that I'm glad we are done in time. Dot 10. Okay, guys. So this is a summary of who's doing what. We know about them. And this is a summary of the movements at the ankle joint. Who's bringing what type of action. Thank you very much. Stay blessed. Stay safe. And I told you, start building up your questionnaire. Send it to me. BLCs will be sending to me, and then we will be looking forward how to answer and when and what are those slots. Gentlemen, can you turn on the lights? So, close. Relax. And